Hi, I am Ronald Lett, CEO of the Canadian Network for International Surgery. The second lecture in the Structured Operative Obstetrics (SOO) course is on the relevant surgical anatomy. This slide shows a sagittal section of the female pelvic anatomy viewed from the woman's right side. This view provides crucial insights into the relationships of female pelvic structures, which is essential for understanding reproductive anatomy. Not visible in this view are blood vessels, the internal iliac artery and its branches, including the uterine artery, supply the pelvic organs. Nerves like the pudendal nerve innervate the external genitalia and perineum. You see the close relationship between the bony pelvis, urinary bladder, uterus, rectum, and sacrum. 1. External genitalia. The labia majora, thick skin folds, and labia minora, thin mucus folds, are visible externally. 2. Vagina. This canal extends from the vestibule to the cervix. 3. Uterus, located superior to the vagina. The uterus consists of the body and cervix. 4. Urinary system. The urethra is anterior to the vagina, and the urinary bladder is situated anterosuperior to the uterus. 5. Rectum, located posterior to the vagina and the uterus. 6. The pelvic floor muscles include the levator ani muscle, which forms the pelvic floor. 7. Peritoneum. This membrane covers various pelvic organs, forming pouches such as the rectouterine pouch, pouch of Douglas, posterior to the uterus. 8. Ligaments. The broad ligament supports the uterus, while other ligaments, like the round ligament of the uterus, are also visible. By thoroughly understanding female anatomy, cesarean section providers can ensure safer procedures, reduce complications, and improve outcomes for both mother and baby. Knowledge of anatomy helps optimize incision placement and avoid complications. Understanding anatomical variations due to adhesions and uterine scars is essential for making decisions on the technique of future deliveries. To conduct any surgical intervention safely, it is necessary to appreciate the anatomy that is involved. In one study, 90% of specialist obstetricians thought it was important for trainees to know about the rectus muscle and sheath. Uterus, tube, mesosalpinx, ovary, infundibular pelvic ligament and blood vessels, bladder, omentum, uterine vessels, uterosacral ligament, cardinal ligament, broad ligament and the externa, and internal anal sphincters. It is important to know the relationship of organs with each other, their blood supply and nerve supply. The bladder is located anteriorly in the pelvis, just behind the pubic symphysis. The urethra, a short tube that extends from the bladder to the external urethral opening, lies anterior to the vagina. The bladder and urethra are separated from the vagina by the pubocervical fascia. The vagina is positioned between the urethra anteriorly and the rectum posteriorly. It extends from the cervix to the vaginal opening. The rectum is separated from the vagina by the rectovaginal fascia. The uterus is situated superior to the vagina, with the cervix forming the lower portion that connects to the vagina. The cervix is connected to the fascia of the anterior and posterior vaginal walls, providing support for the uterus. The uterus is supported by various ligaments, including the broad ligament, which also supports the fallopian tubes and ovaries. The rectum is located posteriorly, behind the vagina and uterus. Anatomical changes in pregnancy are primarily driven by hormonal influences, particularly estrogen and relaxin, as well as the mechanical pressure exerted by the growing fetus and uterus. These anatomical adaptations allow the body to accommodate the growing pregnant uterus while maintaining maternal physiological functions. The bladder remains loosely attached to the front of the uterus. It must be mobilized during a C-section. The bladder can be firmly scarred to the front of the uterus if there has been a prior C-section. The bowel tends to be pushed back by the pregnant uterus. It still may be harmed during surgery, but less often than the bladder. The uterus enlarges up to 20 times in size, ascending from the pelvis into the abdominal cavity. This displaces abdominal organs and alters the positioning of surrounding structures. The growing uterus pushes the bladder anteriorly and inferiorly. The enlarging uterus elevates the diaphragm, pushing the heart upward, to the left, and somewhat forward, making the heart appear larger on X-ray examination. The expanding uterus also displaced the stomach and intestines upward and laterally. The symphysis pubis and sacroiliac joints experience increased laxity, accommodating fetal passage during birth. The center of gravity shifts posteriorly, often leading to an increase in lumbar lordosis and thoracic kyphosis abdominal muscles. The rectus abdominis muscles elongate and separate along the linea alba. In this diagram, the woman is lying on her back with her head to the left. During a cesarean section, the uterine incision is usually made in the front wall of the uterus, low down behind the bladder, where the surgeon's finger is pointing in this diagram. This area is called the lower uterine segment. When a low transverse incision is made here, rather than a vertical higher incision, there is less bleeding and less risk of uterine rupture in future pregnancies. Therefore, the bladder must be identified and mobilized before entering the lower uterus during a cesarean section. To avoid injury to the bladder, surgeons must be aware of its relationship to the lower uterine segment. A Foley catheter helps with bladder identification. The surgeon must know the blood supply to the abdominal wall and the uterus. Abdominal midline is less vascular than lateral tissue because vessels tend to come from the sides and branch. The anterior abdominal wall muscles can be divided into two groups. 1. Flat muscles located laterally include the external oblique, a middle layer of the internal oblique, and the deepest layer, the transversus abdominis. 2. Vertical muscles, near midline the rectus abdominis muscles are large vertical muscle on either side of the linea alba. The pyramidalis is a small triangular muscle superficial to the inferior rectus abdominis. The blood supply to the anterior abdominal wall includes the superior epigastric artery, a branch of the internal thoracic artery, and the inferior epigastric artery, a branch of the external iliac artery. The innervation of the anterior abdominal wall muscles primarily comes from the thoracoabdominal nerves, T7 to T11, which supply most of the anterolateral abdominal muscles. The iliohypogastric and ilioinguinal nerves supply lower fibers of the internal oblique and transversus abdominis. In this diagram, the low abdominal incision is being viewed from the direction of the woman's feet. Phalansteal incision has been started. A phalansteal incision is a transverse lower abdominal incision commonly used for cesarean sections and other pelvic surgeries. Here the skin, fat, and fascia have been divided transversely. The fascia is being separated up off the rectus muscles. The incision is about 2 finger breadths above the pubic symphysis, extending laterally towards the anterior superior iliac spines. This layer contains the superficial epigastric vessels, which may require ligation if the incision is wide. After dissecting through subcutaneous fat, the anterior rectus sheath is divided transversely. The rectus abdominis muscles are separated vertically along the midline, preserving the muscle fibers. The peritoneum is entered vertically. The pregnant uterus is one of the most vascular organs in the body. At term, blood flow to the uterus reaches about 700 milliliters per minute or 15% of maternal cardiac output. You must know the vessel that supply the uterus. Uterine arteries are the major blood supply to the uterus, with significant collateral blood supply via ovarian vessels. The uterine arteries originate from the internal iliac arteries, while the ovarian artery originates from the aorta. The ovarian artery supplies the mid-portion of the ureter, the ovaries, and the tubes. This image, from the woman's left, depicts both the arterial and venous circulation of the pelvis. The uterine artery originates from the anterior division of the internal iliac artery. It courses through the cardinal ligament to reach the uterus. The uterine artery crosses the ureter anteriorly. Remember, water under the bridge. The uterine artery divides into ascending and descending branches at the cervical-uterine junction. In this image, looking down into the pelvis with the sacrum at the bottom, note the relationship of the ureter highlighted in yellow, located beneath the uterine arteries. Attempts to control arterial bleeding without precise visualizations can harm the ureter. In this diagram, the sacrum is toward the top. Be aware of the potential harm to the ureter during cesarean section. 80 to 90% of ureteral injuries occur in the pelvic segment of the ureter, closest to the bladder. The pelvic segment of the ureter is highlighted in this image. Maintain meticulous surgical technique and good exposure. In case of sudden hemorrhage, use direct pressure and sharp dissection rather than blind cautery or suturing to control hemorrhage. Blind attempts at hemostasis are the cause of most ureteric injuries during the cesarean section. The better you know your anomaly, the safer you will be as a surgeon.